is also not reporting.
Hello, everyone, and welcome to today's webinar, Hemorrhagic Stroke Update in Get With the Guidelines Stroke. My name is Sue Abelt, and I'm a program consultant for hemorrhagic stroke with the American Heart Association. Before we get started, I'd like to go over a few items so you know how to participate in today's event. Next slide. The webinar is being recorded and will be sent via email within 24 hours. There are no CEs associated with this webinar, but you may access a certificate of completion in your follow-up email after the conclusion of today's event. You will have the opportunity to submit text questions by typing them into the questions pane in the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. If you do experience any technical issues during the presentation, most can be resolved by refreshing your browser. If your issue is not resolved following the refresh, please refer to the GoToWebinar customer service team, whose contact information can be found in your webinar confirmation email. Next slide. So let's take a look at a high-level overview of today's agenda. We will hear from Dr. Navi Sangha, who will review the AHA scientific guidelines for anticoagulant reversal. We'll discuss the progression of our ICH performance and quality measures, and then outline the updates to the upcoming Get With the Guidelines Stroke Registry. Next slide. So now it is my pleasure to introduce today's presenter. Next slide. Dr. Navi Sangha received his neurology training at Kaiser Permanente Los Angeles Medical Center and completed his vascular neurology fellowship at the University of Texas, Houston. He is currently the Regional Medical Director for Stroke and Telestroke at Kaiser Permanente Southern California and an associate professor at the Kaiser Permanente Bernard J. Tyson School of Medicine. Dr. Sangha's interests include improving systems of care to help implement processes that improve clinical outcomes at both primary and comprehensive stroke centers. As well, he enrolls patients into stroke clinical trials at primary stroke centers via telemedicine in order to decrease disparity of care in clinical trial enrollment. Dr. Sangha, the floor is yours.
Thank you, Susan. I have no disclosures. Next slide, please. So we're going to be talking about anticoagulant reversal, as Susan said earlier, specifically discussing why it's important to reverse patients, the agents we can use to reverse them, and subsequently what the new measures may be looking at for these patients specifically. So very recently, a publication by Dr. Kevin Sheth using the Get With the Guidelines data showed that time to anticoagulation reversal really affected the outcomes of patients who had intracerebral hemorrhages related to anticoagulation. They found that it was improved with survival if patients received reversal earlier compared to those who received it later. There's also a statement in the 2022 American Heart Association and Stroke Association intracerebral hemorrhage guideline, which says specifically that in patients with anticoagulant-associated spontaneous ICH, that anticoagulation should be discontinued immediately and rapid reversal of anticoagulation should be performed as soon as possible after the diagnosis of spontaneous ICH to improve survival. So this is really an evidence-based method to treat your patients and to improve their outcomes. We don't have a lot of things that can improve outcomes in patients with intracerebral hemorrhage, and we believe that this may be one of the things which is a low-hanging fruit that we can institute to improve those outcomes. Next slide. And how can we reverse patients' anticoagulation when they come in? So of course, you would need to understand when the patient's last known well time was, as well as when their last dose of anticoagulation therapy was. When they get to you, it's important to know what anticoagulant they're on. if that history is available, and if the patient is able to tell you that they recently took their anticoagulant, or even if there's an unknown time from which their anticoagulant was last taken, it's important to reverse the patients. The reason it's important to reverse if there's an unknown time, for example, if a patient's brought in via EMS and they themselves can't provide the history, but you do know in their chart that they have a known anticoagulant that they're taking and family isn't available, it's important just to assume that the patient may have taken their anticoagulant at their last likely dose, may have been the night before or that morning. And so if the patient receives a vitamin K antagonist and their INR is between 1.3 to 1.9, it's recommended that we get 4-factor PCC, 10 to 20 international units per kg. If their INR is greater than 2.0, give 4-factor PCC, 25 to 50 international units per kg, and give vitamin K as well. If you haven't already instituted something like this, I do recommend instituting a anticoagulation reversal order set or an emergency anticoagulation reversal order set at your institutes, where they may auto check these things. So if you open up the vitamin K antagonist section, you'll auto check the 4-factor PCC and the vitamin K for the patient specifically. For vitamin K antagonists, it is important to recheck that INR about an hour after the PCC is completed to make sure the patient's INR is at goal of less than 1.3. Now, we may think that this is not the most practical thing where we're waiting for the INR, because sometimes the INR does take time, and individuals may choose to just proceed directly with 25 to 50 units of 25 to 50 international units per kg prior to the INR coming back. It's fairly a safe drug overall for patients to receive 4-factor PCC if they have a known intake of a vitamin K antagonist. Another commonly used medication, well, not so commonly in the United States, but definitely commonly used in Europe and other countries, is dabigatran. And so, of course, it's important to know when the dose was last taken. If the patient did receive dabigatran within the last 2 hours, consider giving activated charcoal. That can be practically difficult, but if possible, go ahead and proceed with that. And if idarucizumab is available at your institute, go ahead and give that. But if it's not available, then you can revert to the 4-factor PCC. The dose for the 4-factor PCC or an activated PCC would be the highest dose in these patients, 50 international units per kg. Looking at our factor Xa inhibitors, specifically apixaban and rivaroxaban, which are commonly used, edoxaban can also be put into this category. It's not as commonly used, however. You also want to follow that workflow. Similarly, if the patient did receive that DOAC within the 2-hour period, consider giving the activated charcoal if feasible, and if possible, then proceed to giving them the reversal agent. Adnexnet alpha can be used, but you can also use 4-factor PCC. Now, this guideline was published in 2022 prior to the ANNEXA-4 study, which showed that there may have been some adverse events with adnexnet alpha. And so not all institutes have adnexnet alpha, and so it's okay to proceed with 4-factor PCC if you feel comfortable doing so. And if the patient is on a heparin, oftentimes they're not on unfractionated IV heparin as an outpatient. They could be an inpatient, however, and they may have a code stroke. You want to consider giving them protamine. If they're on a low molecular weight heparin, which they can definitely be as an outpatient and come to you in the emergency department, you can also consider giving protamine to them as well. Protamine is more effective in reversing unfractionated heparin compared to low molecular weight heparin, but it is still somewhat useful in low molecular weight heparin as well. The next slide, please. Next slide, please. Can you guys advance to the next slide? It's not advancing. Thank you. So in order to ensure that we're following guidelines as well as getting our ICH patients treated, there's actually a publication by Dr. Li Qiu recently in 2024, earlier this year actually, which really recommends following a code stroke paradigm similar to what we do for acute ischemic stroke. So we know for patients with acute ischemic stroke, when they come in, we have clear imaging we're going to get for them. We have clear blood pressure parameters for them if they're going to be a thrombolytic patient or a post-thromb or a non-thrombolytic patient. We do have hematologic therapies in terms of tissue plasminogen activator or tenecteplase for them, and of course surgical intervention as well, such as EVT. But for intracerebral hemorrhage, it's not commonly followed. These paradigms are not commonly followed at many institutes, and very specifically, there's no standards for emergency reversal of anticoagulation. We do have definite reversal agents that we can use, like we spoke about earlier, but there's really no clear standards where it's recommended to treat a patient quickly within 60 or 90 minutes. And I think that's going to be really important in the subsequent slides where we begin to define door times to treatment times for these patients in order to get that reversal agent to the patient quickly and prevent that hematoma expansion. But overall, for intracerebral hemorrhage, if a patient comes in, they should get imaging rapidly. Of course, with a non-contrast head CT, maybe consider a CTA with them. They should have rapid blood pressure control as well, getting that blood pressure to a systolic of less than 150 likely and keeping it between 130 to 150, reversing their anticoagulation if they're on it, and then maybe even consider surgical intervention if it made sense for that patient based on their specific location of the hematoma. Next slide, and I'll pass it over to Susan, back to you guys.
Thank you, Dr. Sangha. As a reminder, please submit your questions into the question pane at any time during the presentation today. So taking a turn, I will hand the presentation over to Kim Chapoy-Casas, who is our American Heart Association Senior Product Manager for Health IT for Get With the Guidelines Stroke. I'll turn it over to you, Kim.
Great, thank you, Sue. Before I go ahead, can you just confirm my audio sounds okay?
It's great, thank you.
Perfect, thank you. So good afternoon, everyone. As Sue mentioned, I'm going to be providing an overview of enhancements that we've been working on for the Get With the Guidelines Stroke ICH layer and share with you all specifically what changes you can expect in our December release coming in a couple weeks. As many of you may know, we launched the ICH layer in Get With the Guidelines Stroke in 2023, and we had a lot of great engagement in that layer and sites that, many sites that immediately turned on that layer to begin capturing more specific data on these ICH patients. When the layer launched, and currently, the measures that are available for sites are those that you see on the screen here. So we have 11 rate-based measures and 5 descriptive measures available, again, to sites that have this ICH layer. Go ahead to the next slide. With any layer that we deploy into Get With the Guidelines Stroke, there's sort of a natural cycle or progression that the measures may move through. We often refine measures based on the latest treatment guidelines and science, and if relevant for the disease, any nationally published performance measures. We also update measures if we need to support a new AHA Get With the Guidelines quality initiative. We make updates if there are suggestions by oversight or work group committees. They may identify a gap in care or an opportunity to capture more important data. So for any of these reasons, we may assess our measures and make enhancements or develop new complementary measures. Go ahead to the next slide, please. So the Get With the Guidelines Stroke ICH measures available in the tool now, again, released back in 2023. Those were based on ICH treatment guidelines at that time and 2018 performance measures. So I'm sure many of you know in 2024, there was a newly published clinical and performance measures for ICH. So sort of to piggyback off that last slide, the publication of these 2024 clinical performance and quality measures was really an opportunity for us at the HA and within the Get With the Guidelines Stroke program to review the existing ICH measures and make updates to better align with the recently published performance measures. Go ahead, next slide, please. So over the past, I'd say it's been about a year or so, the AHA has been reviewing the ICH measures with several work groups, several oversight committees, and we identified both updates to existing measures that we want to deploy to all of you and some new measures that we'll be deploying. So on the slide here, you'll see a summary of those measure enhancements that we are planning. As you can see here, it's a pretty big scope, both from a technical perspective and to give you all at sites time to become familiar with these changes and to have proper education. We are going to deploy these in a phased approach. So you'll see phase 1 or release 1 up on the top left is focused on reversal measures. So this will include both revisions to existing reversal measures and some new measures that we'll be deploying. These updates will be deployed in our December release in just a couple weeks. This will be the focus of the rest of the webinar today, is sharing these updates with all of you. In addition to that release, we did want to give you a sort of sneak peek at what to expect in the next 2 phases for the ICH layer. So we're aiming in the spring of 2025 to share updates with you all for any measures that are not reversal related. So for our existing ICH measures, that's VT prophylaxis, your dysphagia screening measures, admission unit, inappropriate platelet transfusion, and blood pressure treatment at discharge. Some of these will be pretty minor changes to the measure, and others will be a little bit more comprehensive. And then we're really excited to share that we'll be deploying a number of new measures in this phase as well. 2 of them are relevant for our systems of care with EMS, so whether a stroke severity screen was performed and reported for our ICH patients, and then same for ICH patients for pre-notification. And then we're also planning to add a measure on rapid neuroimaging, some metrics on time to administration of a BP lowering agent and time to BP control. And then finally, an inappropriate platelet transfusion measure that's inclusive of all ICH patients. So we will share more information on what to expect in those measures in the future, but we wanted to know, or wanted to share with you all that those are coming, and we've heard a lot, especially around that the BP control, that many of you are looking for measures on these. So expect them to come out next year. And then finally, we're working on a transfer out bundle. These measures are yet to be developed, but we know that there are many primary stroke centers that are participating in the ICH layer, entering in really important data on these ICH cases, but the current measure set does not include patients that are not admitted. So we want to make sure there are measures available that specifically focus on patients that are not admitted, they're transferred out. So just expect more information on that phase 3 in the future as well. Something just really important to note before we go on to these other slides is that all these measures are being deployed as reporting measures into Get With the Guidelines Stroke. None of these measures are elevated to the achievement, quality, or award program classification at this time. Often our goal with deploying reporting measures is to analyze them over time, see if they meet the requirements for being elevated to an award program measure. So we will certainly have that consideration for these measures, but at this time, these are all deployed as reporting measures into Get With the Guidelines Stroke. Okay, next slide, please. So for our December release with the updates to any reversal measures, they will be deployed into the system on Saturday, December 14th. Just with any other Get With the Guidelines Stroke release, there will be some system downtime. You can expect the system maintenance to occur between 12 a.m. Eastern Time on Saturday, December 14th, to 12 a.m. Eastern Time on Monday, December 16th. So we recommend you save all your work and log out of the system by 11:45 p.m. on Friday, December 13th. These ICH updates are just a subset of the items that will be in our December release. So keep an eye out for release notes that'll come out next week to all users. It'll have a more in-depth summary of these ICH layer updates, as well as a summary of other enhancements that you can expect in the tool with the December release. Okay, next slide. So the table on the slide here is a summary of the measure changes that you will see with the December release. So we have one existing measure that we will make a revision to. That is the anticoagulant reversal agent measure. It is a distribution measure. It simply groups patients by the reversal agent that was administered. So we will be revising that measure logic. And then we will have 5 new measures deployed related to anticoagulant reversal. We'll go through the changes to all of these measures in the next few slides. Go ahead to the next slide, please. Next slide, please. Before we walk through the revised and new measures, just wanted to make sure everyone is aware that you can expect a copy of the measure logic to be in the Get With The Guidelines stroke library at the time of the release. These slides are available to you. They are in the handout section of the webinar today, so you can certainly reference these slides, but it will be a high-level overview if you really want to dig into the measure logic. The measures description document is a great resource. Again, it'll be available to you in the library at the time of the December release. So the first measure we're looking at is AHA-STR 299, anticoagulant reversal agents. This is, again, an existing measure. You have it available to you already. We are just making some revisions to that measure. It is focused on patients that have received an anticoagulant reversal at this hospital. And then among those patients, there are a number of exclusions, but any patient that still remains in the denominator will be grouped into categories based on the reversal agent that was administered to that patient. Something to keep in mind is that we're making some changes to abstraction and selecting reversal agents. So it will be multi-select moving forward. And so a case can fall into multiple categories in this distribution measure if they received, multiple reversal agents. You'll also notice at the bottom, in the bottom box, some reversal agents in gray. These are ones that are newly added response options. We'll be going over the case report form changes associated with these later in the slides, but just wanted to point out that these are new. And so when you run this measure, just keep in mind that you will only see data in these groups for time periods that you abstracted on the new response options. Okay, next slide, please. For the next 3 slides, you'll see that we created a separate rate-based reversal measure for warfarin, DOAC, and heparin. So each will independently evaluate whether an appropriate agent was given specific to the anticoagulant that the patient presented on. For this first one, which is anticoagulant reversal for warfarin, this includes patients on warfarin prior to arrival, and INR is at 1.4 or greater. You'll see here there's also a number of exclusions and exceptions. A new exception that you can expect with this release is documented reason for delay in reversal agent. We did not previously have this data capture, but we will be adding it as an opportunity for you to capture reasons for delay, and certain reasons will be exceptions in this measure. And then among those patients, the numerator is evaluating acceptable therapies within 90 minutes of arrival. For all of these measures, acceptable therapies are defined as class of recommendation 2B or higher. And on each of these slides, you can see in the lower left, all of the therapies that are classified as 2B or higher. This measure also includes some newly added data elements and response options. So sites should restrict running these measures on time periods for which you've done abstraction on these new data elements and new measures. So that would be cases entered after the December release. If your site would like to go back to existing records entered prior to the release and enter data for these new data elements and response options, it will be available to you. You could certainly do that, and then you can run the measures for those retrospective timeframe. But again, if you do not want to go back and abstract data and the new elements and response options, you can just abstract these new response options going forward and then restrict running the measures to cases entered after the December release. Okay, go ahead, next slide, please. So next we have the anticoagulant reversal DOAC measure. So this is focusing on patients on a factor Xa inhibitor or dabigatran prior to arrival, and last known dose is unknown or within 24 hours of arrival. Again, we'll have a number of exclusions and exceptions in this measure, and then the patients are assessed for acceptable therapies within 90 minutes of arrival. Again, acceptable therapies are in the lower left-hand corner here, and those are defined as class of recommendation 2B or higher. Similar to our last measure, we have some newly added response options and data elements that are used in this measure. So you'll want to restrict your running this on cases entered after the December release if you're not retrospectively entering in data on the new elements. Something I didn't mention on the last measure, pertains to the last measure, warfarin and this DOAC one. We do have existing DOAC and warfarin measures in the tool, the ones that you all have available to you now. We are maintaining them in the tool, unchanged, no logic is changing. Those will be labeled 2023 version. So that will be available to you again, both for the warfarin existing measure and the DOAC existing measure. So you'll notice for this DOAC measure, and then this will be applicable on the next measure, we'll review the heparin measure as well. The denominator considers the time of last dose of the anticoagulant. We did consider when constructing this measure that oftentimes the time of dose is unknown. So in the circumstance of an unknown time, the case would default to being included in the measure. The time of last dose is instead going to be used if we know the time of the last dose. It will take patients out of the measure if their last dose was before a certain period, certain number of hours prior to arrival. So if we know here on the DOAC, if you know the time, enter the time into the registry, the patient will come out of the measure if it was more than 24 hours from arrival. Next slide, please. Next, we have the anticoagulant reversal heparin measure. This is again, a newly added rate-based measure with this release. There was previously no existing measure evaluating heparin reversal, so no 2023 version of this measure. This is focusing on patients that received unfractioned heparin and their last dose is either unknown or within 24 hours of arrival, or patient received low molecular weight heparin prior to arrival and last known dose is unknown or within 12 hours of arrival. Again, we have some standard exclusions and exceptions, and the numerator will evaluate acceptable therapies within 90 minutes of arrival. For heparin, that that acceptable therapy is IV protamine. Again, still using that same definition, class of recommendation 2B or higher. Next slide. So we're sort of changing paths a bit. This next measure is a roll-up measure. So it is a roll-up of the warfarin, DOAC, and heparin measures that I just reviewed. It includes all of those patients that meet those denominators in this single measure. So patients on any anticoagulant at arrival, so warfarin, factor 10A, dabigatran, or heparin, all of those cases will be included in the denominator here. And then, of course, we'll have sort of those standard exclusions and exceptions. And then it will evaluate whether each of those patients had an acceptable therapy within 90 minutes of arrival. So it will assess the therapy relative to the anticoagulant that the patient presented on. Go ahead, next slide, please. We have an exact copy of that 90-minute measure, but the benchmark for the numerator will be 60 minutes. So we wanted to provide hospitals a couple different ways to evaluate timeliness of reversal therapy. So you will have both a 90-minute benchmark roll-up measure and a 60-minute benchmark roll-up measure. Okay, next slide, please. So that concludes the updates to the measures that you'll see in the upcoming December release. But as you can imagine, with some of the changes we've made to the measures, it will require some changes to the data collection or the case report form. So this is a summary here of the CRF updates that you can expect with this release. We will have 3 existing elements that there will be revisions to, and then we will have 7 new data elements. We did apply logic so that you will only be abstracting data and data elements that are relevant for that patient. So what we call conditional show and require validations. So for example, if the patient received a reversal within 90 minutes of arrival, you will not be prompted to answer the question on reasons for delay for providing the reversal agent within 90 minutes. So we'll go through each of these in detail in the next few slides. Next slide, please. We have 3 elements in the ICH layer now that capture data on reversal agent. So we have one on the reversal agent prior to arrival, a second on reversal agent administered at this hospital, and then third, reversal agent used for redosing. Each of these 3 existing data elements will be updated similarly across the 3 elements. So you can see on the screen here a before and after shot. We have the 3 major changes here are that first, it will become a multi-select. Second is that if you select PCC, you will be prompted to indicate whether it was a 3-factor or a 4-factor PCC. We will be adding activated PCC as a response option, and IV protamine will now also be a response option. Next slide. On the screen here are 2 new data elements that you will see. So the first is other reversal therapies prior to arrival. So you'll have the response options of activated charcoal, renal replacement therapy, and other non-pharmacological therapy. If you indicate other, you will have a free text box where you can enter in text of the other therapy. And then we will have basically a mirrored data element for therapies, other therapies administered at this hospital. We will also be adding a new data element for date and time of last anticoagulant dose prior to admission. This will be in the admission tab, where you're probably familiar with entering any antiplatelet or anticoagulant the patient was on prior to admission. If you enter that the patient was on an anticoagulant, you will then see a new data element show that prompts you to answer the date and time of last anticoagulant dose. We will have precisions available where you can select unknown, date only, or that you have the date and time. So you have all of those precision options. And again, we do know that the abstraction for this data element, with the variations in documentation that you may see, and instances in where a specific time is not documented, we want to provide you as much guidance as possible on how to abstract this. So you will have coding instructions available to you that will give some examples. We will indicate how to abstract if you see the time just specified as number of hours prior to arrival. We will also have instructions for when you see range of time prior to arrival. So if it says like 2 to 3 hours ago, and also how to abstract if the time is not specified in the documentation. Okay, next slide, please. We will also be adding new data elements for indicating reasons for delay in reversal therapy. So first, if reversal therapy was initiated greater than 60 minutes after arrival, you'll get a yes/no question to answer of whether there were reasons for delay. If you indicate yes, you will then be prompted to enter in the specific reasons. Think of these data elements as similar to those that you answer on whether there were delays for door to needle within the 30, 45, and 60-minute timeframes. So these elements will not show if a reversal agent was given within the specified timeframe. So, for example, if you have a patient that comes in and a reversal agent was given within 75 minutes of arrival, you'll want to answer the questions on reasons for delay within 60 minutes, but you will not be prompted to answer in a reason for delay within the 90-minute time frame. You'll see here you also have an opportunity to enter in free text if you have documentation of a reason that does not fall under these specified options. Something to note is that the elements with the asterisks are not exceptions in the 60 and 90-minute evaluation measures. So these are for tracking reasons for delay, but they will not be exceptions in the measures. Similar to the date and time of anticoagulant dose, we will have detailed coding instructions available to you for these. They will be in the Get With the Guidelines stroke library after the release. You can expect a lot of similarities to the instructions for documenting delays for IV thrombolytics. It will look very similar for the documentation requirements. Okay, next slide. Okay, I think I will turn it back over to, I think I'm turning it over to Jeannie to start our Q&A session.
Okay, thank you, Navi, and thank you, Kim. We have a lot of questions. We have a lot of people on today and a lot of questions, so we're going to see what we can get through. Just as a disclaimer, if you have any questions after the webinar, or if you have any issues with any of your Get With Guidelines, feel free to reach out to your quality consultant. So I'm going to put some of these questions together since some were duplicate. So I think this first question is for Navi. Navi, is there a national average for mortality for ICH and ICH with intervention? So I guess ICH overall, ICH related to DOAC, and ICH related to DOAC with intervention, if I can paraphrase for the person asking the question.
Yeah, no, that's a really great question. About if it's ICH related to anticoagulation, or specifically, there's about a 50% mortality rate in the first 30 days, actually, so a really high mortality rate. And the major driver of that is due to hematoma expansion. ICH by itself portends about a 20% mortality rate.
Jeannie, you're still on mute if you're asking a follow-up.
Yeah, I lost Navi's sound there for a minute. So, okay. There is another question here. There's several questions around procoagulant treatment for INR greater than 1.4. Is there any thought to aligning with INR 1.3 for standardization of care? And there's several questions around using the INR 1.3 versus the INR 1.4.
So I can take that too again, Jeannie, if that's okay. You guys can hear me okay?
I can. Perfect. Thank you,
Yeah.
Navi.
Yeah, so currently the new guidelines, they recommend a treatment of INR of 1.3 or greater. And so I believe that's where the standardization is going to lie, and that's what our measures are going to be also looking at as well. So we're going to be looking at patients who have an INR of 1.3 or greater, and that is the current recommendations for the 2022 ICH guidelines.
Thank you. There's another question. I think this may be you as well, Navi. Could you respond to the recent article about Indexa that shows ICH volume reduction, but not improvement in patient outcomes?
Yeah, that's a good question. So it is a little bit complex, the study itself. And so there was clear reduction in volume, but there was also a 10% increased risk of ischemic stroke. And so when you're trying to weigh the risk of the ischemic stroke with the hematoma volume reduction and the not necessarily clear improvement of outcomes, then one might consider using another agent depending upon what your local hospital has decided and their protocols show. So the guidelines were published based on previous articles for adnexnate alpha, and so that's why it received a class 2A level of evidence compared to 4-factor PCC. But going forward, we feel like you may use either agent to reverse the patient.
Thank you. There's a question here. Are there any specific tools being used for ED triage for walk-ins to help with capturing possible ICH, SAH in this population? I guess they're talking about screening tools for identification. Yes.
Yeah, that's a really good question, actually. I'm actually personally not aware of any current screening tools, but I think this is a big topic of discussion, and some of our colleagues are actually working on that currently. We do know that intracerebral hemorrhage at times can present with the BFAST symptoms, and so using your usual BFAST symptoms for screening like you do for ischemic stroke is helpful. However, percent of the population of intracerebral hemorrhage, even as high as 20 to 25%, can present with vague symptoms, lethargy, headache, nausea and vomiting, and really not have any focal symptoms at all. And so there is some research that's actively going on considering looking at scoring systems for these patients who come in to consider triaging them quickly when they have those vague symptoms.
Great, thank you. There's a question here about blood pressure management. So what time frame should blood pressure treatment for ICH begin, and how long should it take to get to goal?
Yeah, that's a really good question. I can tell you from our experience, our system-wide experience, we tend to be really aggressive. But our measures that will be coming out in the future, we have goals that we can talk about as well. I think, Jeannie, can I speak about those goals?
Absolutely.
Okay, great. And so the patients who present within 2 hours of their last known well time, those are the patients who are going to have the biggest bang for their buck. We know this based on subgroup analyses of the INTERACT studies and the ATAC studies, that the patients who presented the earliest and had their blood pressure reduced down to a systolic of less than 150, but not necessarily less than 130, but just keeping it in that sweet spot between 130 to 150, they had the greatest benefit. And a really recent study that was just published this year, INTRACT 4, which was a study done in China, showed that patients who received acute blood pressure management in the field, not knowing if they had an ischemic stroke or intracerebral hemorrhage, found that patients who had the intracerebral hemorrhage as a final diagnosis had an improved outcome compared to those that had an ischemic stroke. They actually had a worsened outcome. And so we know that patients who present early in their symptoms, that they are the ones who are low-hanging fruit, and we should really try to reduce their blood pressures quickly. I do think it's important to consider creating metrics and time intervals in your emergency departments to figure out how quickly are you treating these patients. Maybe follow a system that's similar to your acute ischemic stroke patients, for example, where you measure how quickly a patient had a CT scan, how quickly were the labs drawn, how quickly was a thrombolytic ordered, and how quickly was a thrombolytic administered. Something that you can do similarly for intracerebral hemorrhage patients is that how quickly did the patient get their CT scan, how quickly was the blood pressure medication ordered, how quickly was the blood pressure medication administered, and then how quickly was the blood pressure, how quickly did the blood pressure reach its goal, usually measured by at least two intervals of, at least two readings of systolic blood pressure getting to 150 within 5 minutes of each other. And so I really encourage the audience to understand what their local metrics are in the emergency departments. If you don't have local metrics, you can really consider looking at them and developing them to improve the intracerebral hemorrhage care for the patients. Within our system, we will be coming out with metrics and recommendations and measures for everyone to kind of try to meet. And it's going to be trying to get that goal blood pressure within 90 minutes and then within 120 minutes from hitting the door.
Great information. Sounds like another webinar for Navi to do for us. On
Can
blood
I
pressure
add
management.
something on that from the tool
Yes.
perspective?
Sure.
Thanks, Dr. Singer. That was really helpful. And I think to go along with that comment about tracking at your hospitals, we do not have a measure deployed at this time. That's part of our phase 2, or those blood pressure treatment metrics. But we do have data elements in the tool where you can capture date and time of first administration of a BP lowering agent at your hospital, and date and time the systolic BP was first sustained at 149 or less for at least 5 minutes. So you can pull that data from the data download report if it's something that you want to start to analyze through like an Excel at this time before we get those measures out to you all.
Thanks, Tim.
Jeannie, before you go to the next question, I misspoke about the ICH mortality. I said 20%, that's their morbidity. 20% of patients at 6 months are actually functional, and the majority are not. But non-anticoagulation mortality can be between 30 to 40%. Anticoagulation-related mortality is around 50%. I apologize for that. I wanted to correct that. I just realized.
No, thank you for clarifying. There's another question here, and I think this is about ICH overall. This information that we've given on the webinar, is this just for ICH patients taking anticoagulants? Currently, is there a procoagulant reversal guidelines for ICH patients with a high INR, I guess, without taking anticoagulants, like a baseline high INR?
Yeah, that's a good question. There are no guidelines in the AHA guidelines for that. It is recommended to reverse. There are guidelines published by our hematology colleagues that when patients come in with a hemorrhagic disorder and they have an elevated INR, we should consider trying to figure out what that cause of the elevated INR is, for example, liver dysfunction. And if it is that cause, then you want to kind of direct it to that specific dysfunctional cause. For example, if a patient has liver dysfunction, then they're really not producing the correct factors, and you might want to consider giving them FFP or cryoprecipitate along with Kcentra. Kcentra really reverses specifically what warfarin or Coumadin blocks, which is factors 2, 7, 9, and 10, that's why it's 4-factor PCC. But if someone has, for example, liver dysfunction and their INR is elevated, then they may actually have a total factor depletion, and you might really want to consider replacing all the factors, which is best repleted with FFP, maybe in combination with cryoprecipitate, which has a lot of fibrinogen in it. Can also consider adding K-center to that, kind of just throwing the gamut at them. But it's really important to kind of figure out why their INR is elevated. Sometimes it's just like that because of nutritional status. So things to look at, you want to kind of focus on the reason for it and then focus on the treatment. That's a really good question.
Okay, this is kind of a long question, and so can you speak to dosing for PCC standard at 1,500 units for reversal, vitamin K antagonist, 2,000 units for DOAC versus weight-based? Would these be handled differently related to abstraction within the measure?
Yeah. Oh, I see. For the measure, I think I'll let our measure colleagues speak to it, but I can speak to the treatment paradigm. You know, if we go back, are we able to go back to that slide which has the kind of that algorithmic chart on what doses to use for four-factor PCC?
Slide 3, I believe, possibly.
And so what I had spoken about earlier is that oftentimes it's not practical to wait for the INR. I think it's the next couple of slides, sorry. It's not often practical. One more slide.
Next. There you go.
This one right here. So if you look at this slide, it says, kind of gives you a dosing regimen. If the INR is 1.8 or 1.9, you give a certain dose of four-factor PCC. If it's 2.0 or greater, you give a certain dose of four-factor PCC. In practice, what I do, I'll be honest with you, I just go straight to the high dose PCC in patients as long as they don't have a recent history of a thrombotic event like a PE, MI, or a stroke. And the reason being is that we really want to get that reversal agent in quickly. And so I usually end up just going straight to the 25 or 50 units of four-factor PCC. Most of these patients tend to have a weight in them. They are ED patients. It's actually the slide before. Sorry if we can go to that, I apologize. For similar, if you don't have idarosuzumab at your institute, or if you don't have adnexnate alpha, you can also go straight to the highest dose, usually 50 units per kg, four-factor PCC for dabigatran reversal and or reversal with rivaroxaban and apixaban.
Okay.
And I can just, from the measure standpoint, add that the measures don't evaluate dose at this time. So it just evaluates whether an appropriate agent was given relative to the anticoagulant the patient was on.
Great. Thank you, Navi and Kim. So there's a question here that any thoughts on how to document in the electronic medical record the date and time of last dose for patients that have had their medication at home, so that a person during the data abstraction will be easily be able to find this information. I guess they're talking about how are you capturing last dose in your EMR, Navi?
Yeah, specifically for us, the way we capture last dose is, okay, so first it's difficult, I'll admit that. And so oftentimes many patients, it's unknown, the last dose, especially patients with moderate interstitial hemorrhages, if they're coming via EMS, and there's no family members with them, they can't necessarily provide that last dose. But I do want to remind everyone that if the last dose is unknown, you still want to follow that emergent reversal paradigm and assume that they took their last dose the night before or that morning. The DOACs are both dabigatran and apixaban are BID dosings. Rivaroxaban is once a day dosing, and of course the vitamin K antagonists are once a day dosing. So I would just assume that. And so oftentimes it's unknown for us, but if we do know the dose, we do try to write it in our note. And so the ED teams or the stroke teams will input it in their note specifically that last dose was taken out this time. It is a challenge, and we are hoping that as we put out this measure, it'll encourage individuals to kind of document the last dose time a little bit more readily. And so you can always create smart phrases or smart notes. Oftentimes our EMRs allow that, and you might want to consider a specific ED-ICH smart note, which actually has an area which is a hard stop where you have to write the time the last dose was taken, or consider an option for unknown. That would be my recommendation, and that's what we're going to be moving forward with.
Great. There's a question, I guess this may be for Kim. Will the date and time of last anticoagulant prior to admission be required answering for acute ischemic stroke and SAH patients who were on anticoagulants with the December update? So I guess in addition to the ICH population.
For the ICH population, if the patient is on an anticoagulant prior to arrival, you'll be required to answer the question of date and time last dose, with, again, the understanding there is an unknown option. If it truly is unknown, you would select that. For any other patient not an ICH diagnosis, the data element will be deployed, date and time of anticoagulant dose, but it will not be required on those patients. So you can certainly begin capturing it on all your other patients. We want to make that data element available for all patients on anticoagulants. We also will be deploying, this is aside from the ICH layer, but we're also deploying date and time of last antiplatelet dose to the general stroke form with this release as well. Again, that'll be in the release notes. Also optional to enter in that data if the patient was on an antiplatelet, but we want to make that abstraction available to hospitals now.
And on that line as well, Kim, there's a question. Will ICH patients who have an ICH while an inpatient, will they be included in these metrics? Are they included or exclusion?
Those are exclusions, and that is a common standard exclusion in all of our Get With The Guidelines measures are the inpatient stroke cases.
Thanks. As a reminder, we're getting a lot of questions about the slide decks. The slides are, the PDF of the slides are available in the handout section of your toolbar, and a recording will be sent out within 24 hours. Here's a question here. Are there any drawbacks to treating INR less than 1.3 with 4-factor PCC?
Yeah, that's a good question. And so it is fairly safe. I think the only time you really want to consider waiting for the INR to return is if their patient has a known history of a prothrombotic state in a prothrombotic event, I should say, I apologize, in the recent last 3 months, an ischemic stroke, myocardial infarction, PE, and a DVT. Those tend to be the big four. And so otherwise, it's a fairly safe drug. There are rare reports of allergic reactions and anaphylactic reactions, but if the person is in the emergency setting, that can be quickly treated with epinephrine dosage or a dosage of steroids as well. And so those are really rare things. So overall, it's safe. It does have some prothrombotic concerns, and so you want to just kind of try to ensure that the patient may not have a history of the thrombotic events prior to dosing the patient. Like I said, we tend not to wait for the INR in our system as long as we're fairly confident that the patient doesn't have any known thrombotic events. A lot of our EMRs are actually linked often now, and so if you are using a linked EMR, you can sometimes look in that linked section where maybe the patient's not known to your hospital, but you can go look in their linked section to see what medications they've taken, what their recent events have been. And if you look at that quickly during the code stroke, you might see that they haven't had any thrombotic events and it's okay to proceed.
Perfect. We answered a lot of questions. There's some left, but we're hitting the top of our hour, so I'm going to hand this back to Sue Abel.
Thanks, Jeannie. Thanks, Dr. Senga and Kim, for sharing your time and expertise as we learned more about anticoagulant reversal and the important updates to Get With The Guidelines. And thank you to everyone for attending. Once you leave today's webinar, you will receive a prompt to complete a short survey. We would really appreciate it if you would complete that and provide your feedback. You will also receive a follow-up email in the next 24 to 48 hours with a link to view the recording of today's webinar, as well as a certificate of completion. So on behalf of the American Heart Association and my colleagues, We thank you for your attendance and have a great rest of your day.